Hi, I'm Ingrid Laerdal. As we've seen, COVID-19 has drastically changed the way healthcare providers and educators plan and deliver training and education. We've learned that in order to get healthcare workers up to speed quickly, safely and effectively, remote learning is an extremely valuable methodology. You will hear shortly from our global expert panel on how remote simulation is helping learners build confidence and competence. With this new emerging educational methodology, many nursing programs turn to the INACSL standards of best practice as a source of support. But many still have questions on how to really implement them, and we would love to help. Whether you need assistance in implementing remote simulations or need basic simulator or software training, our global team has the experience to help lead you forwards to what may become the new normal in simulation training. Before I end, I just want to express our sincere gratitude towards healthcare providers and educators like you, using simulation training to help prepare the world for crises like COVID-19 and beyond. We have set a goal to help save 1 million more lives every year by 2030. We know we cannot do it alone, but we can do it together with people like yourself. We hope you enjoy the webinar.
My name is Graham Folds and I'm the Regional Director for Laerdal across the Asia Pacific region. It gives me great pleasure today to welcome a number of attendees from all over the Asia Pacific region, from Canada, from the US and from Latin America. I'd also like to welcome 4 international thought leaders who will be presenting on the first 4 INACSL standards of best practice, as well as to say a big thank you to our team in Canada who will be demonstrating a virtual simulation including a pre-brief and a debrief. The objectives for today are threefold: to discuss the relevance of the INACSL standards of best practice in a COVID era, to demonstrate virtual delivery of a simulation experience, and to discuss the challenges of meeting the INACSL standards of best practice in a virtual environment. The format for today is threefold. Firstly, we have each of our 4 international key thought leaders presenting on one of the first 4 INACSL standards of best practice. Then we have a virtual simulation where a team in Canada will be demonstrating a pre-brief, an actual virtual simulation, and then a debrief of that simulation with a nursing student. And then finally, we have 4 international key thought leaders who will be reflecting on their individual INACSL standard of best practice in the context of the virtual simulation we've just demonstrated. And after this, we will have plenty of time for Q&A. So once again, I hope you enjoyed today's webinar. I hope you find it educationally rewarding and there are some key take-out messages. Thanks everybody, enjoy.
How do the INACSL standards guide simulation when using remote learning principles?
Yeah, thanks, James, and thanks for the opportunity to talk about the INACSL standards, and particularly the INACSL standard of design. So the standard for simulation design is probably, from my perspective, one of the most exciting, but also one of the most important standards, because it really does make that connection between simulation as an educational experience or an educational opportunity, rather than just something that's a pure game or entertainment or something like that. So when the INACSL standards were first envisaged, developed, it took a couple of years for the simulation design standard to show up. And the standards as they are at the moment have been last published in 2016. And so whilst they're currently under review, the standard for simulation design does actually stand up pretty well in terms of designing simulations for distance learning or for a different medium to what we're not really used to. And I guess the standard for design, or the design standard, does actually provide a fantastic starting point for people who might be concerned of where to start or how to translate their simulations that have been traditionally face-to-face into a more online or remote format. So I think the standard, and the standards generally, but this standard in particular, has significant relevance for designing and running simulations via distance learning or remote learning.
I would like to talk about how our College of Nursing used the INACSL standard when using remote learning in COVID-19 outbreak situation here. Our university allowed less than 20% of students to take face-to-face classes. So our College of Nursing provided clinical lab and simulation courses as a hybrid simulation education or hybrid education. The INACSL standard guided us when we designed and conducted classes for hybrid simulation education or hybrid education. For example, considering the level of fourth-year nursing student who completed all the theory courses in the women's nursing course, as a hybrid simulation education, we developed and conducted the postpartum hemorrhage nursing module using web-based simulation vSim and simulator SimMom. Also, in mental health nursing course, as a hybrid education, we developed and conducted a post-traumatic stress disorder nursing module using the teleeducation and standardized patient.
So the INACSL standards were created to essentially include a wide variety of types of simulation. So whether that be mannequin-based simulation, simulation with simulated or standardized patients, but also to an extent to include virtual or remote simulations or remote learning. So the thing that you also have to remember is that the standards of best practice, they are evidence informed and they are based on the best available evidence of that time. So its current standards were published in 2016. They are currently being revised. But that means that even in 2016, if you think about it, we weren't necessarily doing a whole lot of virtual or remote learning and simulation. So if you're looking for a recipe, it's there, but it might not necessarily apply to virtual simulation. You kind of have to think it through a little bit more. There is a ton of evidence that are in the standards, so definitely have a look at that. But what that means is that you have to keep in mind that, like I said, that they were created a few years ago. The literature is where it was at that time. So you really need to go back to the foundational elements of the simulation. Really look at each one of those criteria, especially with things like facilitation, because what you have to do is you have to have a look at what exactly are they asking me to do and how can I apply it to this kind of an environment? Because really going back to basics, including your objectives, including the facilitation, including the debriefing, those are all going to be part of a virtual simulation as well. But you just really need to know how you can apply those standards and kind of massage the standards a little bit more when you're looking at the virtual or remote simulation experience.
Well, the wonderful thing about the standards is that they apply to simulation regardless of the modality. So they're really based in the best evidence around the pedagogy and not necessarily the particular mode or the particular application of simulation. So everything that applies to mannequin simulation also applies when we're using screen-based virtual simulation, or when we're using standardized patient simulation, or when we're using AR or VR. So luckily, one set of standards applies to all.
If we think about specifically about the criterion of the facilitation standard of best practice, how can we practically apply those criterion to remote learning? Can you provide us with an example or two?
Yeah, sure. So in all standards, but more particularly with the standard of facilitation, they do provide you with specific criterion that you need to include in order to meet the standard. But then they also highlight what can happen if you don't meet the standard, just sort of what the consequences are. So for example, with facilitation, the overall consequence of not meeting the standard is that you can have a reduction in engagement within the simulation, which none of us want, but also a decrease in the opportunities for the participants to be successful and meet the expectations of the simulation, which we also don't want. Right. So the criterion, they really give you a bit of a framework to start to use when you're looking at your simulation. So with facilitation, the criterion that they include is that it has to be, you have to have an approach that's appropriate to the level of the learner. So generally this means how much involvement you have with them during the simulation, how much preparatory materials you need to provide them, how many prompts and cues you need to provide them. So really depending on the level of your student and how much experience they have in this kind of environment, make sure that you provide that for them. You also need to include a pre-brief or preparatory materials, because this really does lay out your expectations of the simulation. It kind of like sets the mood of the simulation. So you need to make sure that you do that as well. And again, that will be dependent on the level of your learner. You also need to, like I said before, consider what kind of prompts and cues you might want to include. And in the standard, they talk about realism cues and conceptual cues that you might want to include. So I would encourage people to go and look at the differences between that, because you really need to pay attention to those as well and how you might include these in your simulation. You also do need to support the learner through this experience, which might look a little bit different in the virtual environment just because we're not there in person. So definitely consider what kind of support they need, whether it's technical support, whether it's just an explanation of what they should be doing. So make sure you include that in there as well. So like I said, in remote learning, things will look similar but a little bit different in that you really need to make sure that you attend to all of those because what you have to make sure that you do is that's, like I said before, that sort of sets your foundation. So we try to do these in more like a virtual orientation. So you asked for some examples. So we do that as a virtual orientation for the students, so that way it's something they can kind of go back to if they need additional instructions or whatever. Then they can go back and rewatch these things. We also provide quite a few additional videos for both the facilitators and the students, what to expect in this kind of a virtual environment. So it's really about setting that foundation, because I cannot overemphasize enough the importance of laying that foundation for simulation, because this ultimately affects the way that the simulation unfolds, which can also affect the debriefing. So I know it's not necessarily the in-simulation part that I'm talking about, but if you don't have a good foundation on that simulation, the rest of it can, what's that expression, a house of cards can easily fall down.
In terms of how to practically apply the criterion of outcomes and objectives to remote learning, we need to think about how much you are able to assess or evaluate the level of learning outcomes in the given remote learning situation. Considering the limitation of remote learning, we can use blended taxonomy hierarchical classification of learning domains to level objectives from simple to complex, and also cognitive and affective and psychomotor domain of learning as well. Also, we need to consider expected outcomes, which needs to be driven by the objectives and concept within nursing program curriculum. As I said previously, when you are doing simulation courses for fourth-year nursing students who are about to graduate, we've implemented hybrid simulation education to assess and evaluate how much their practical performance were achieved directly in terms of outcomes and objectives of the course.
Yeah, sure. The how we could apply it. So if let's say we're retrofitting a simulation, and we have a simulation that we're running that is face-to-face that we would consider running remotely, then pull out the standard for simulation design and use it as a I guess a tool to consider the ways in which the simulation that you currently have designed might translate to something remote, what adjustments might need to be made. And whether it actually is viable or not. So the first question, I guess, that's asked or is asked of us when we're looking at the INACSL standard for simulation design is that we're looking at really understanding what the need is or what the purpose is that this simulation needs to address. So, usually, according to the standards, we should be understanding what the problem is that we're trying to address, or what the need is that we would use that we would therefore design a simulation. So what is it that we want to achieve? What is it that we want to do? And by looking at, I guess, the simulations that you have already designed and thinking about, well, what are the what is it that you want to achieve, and is this still going to be relevant for a remote learning situation, is the first hurdle that you need to get over. The second one then is looking at the learning outcomes and objectives. So you either construct them from scratch, or if you have a pre-existing simulation, then what are the objectives of the simulation broadly, of the simulation program, but also what are the learning outcomes that are set for this particular simulation scenario, and are they achievable in a distance learning context? And this is the point that there's two parts, isn't there? One of it is the practicality, the scenario. Can it be replicated via remote? The other part is, can you meet the achievement of the learning outcomes? So can you demonstrate the situation, represent the situation? The other one is, can the students actually attain what you want them to attain? The really nice part about the standards, though, one of the key things I love about this standard in particular, is that it does really focus on simulation as a learning experience rather than a particular mode of simulation. And so whilst we might have developed a simulation scenario based on mannequins or simulated or standardized patients, or indeed games or different technology platforms, might even be a written case study, the standard asks us to look at the quality of the simulation and the design structure of a simulation regardless of what the delivery mode is or what the mode of simulation is. And I think that's where ultimately the value of this standard comes, is because it really is not making us think about delivering simulation in a particular way, but of delivering quality simulation or designing quality simulation. So I think I'll just leave it there. But one more point though before I do would be in the consideration of running the simulation scenario that might already be designed, is to think about the levels of fidelity, or indeed the types of different fidelity or authenticity that you might have in the simulation that is normally face-to-face, or in whatever mode it's normally delivered. And what are those levels of fidelity, realism, authenticity that can be replicated when delivering a simulation or designing a simulation for remote. So sorry, I keep flipping between delivering and designing, because I guess in my mind, I'm always thinking those two things in tandem. One of them is the design component, but then what's the application of that, or what's the operationalization of it? Because again, there might be some, you can't look at any of those parts in isolation. There might be some trade-offs that you can make in terms of the simulation design or the simulation fidelity. But if you can't replicate some of the critical points of the simulation so that students can achieve the learning outcome set, then we're going to have to change something. We're going to have to either change the learning outcome or outcomes, or we're going to have to change the scenario itself. Something may need to give. So overall, the standard has incredible applicability for remote learning.
Sure. So all 5 of the criterion in the debriefing standard apply to simulation, regardless again of the modality. So criterion 1 is that the debriefer is the debriefing is facilitated by a person who is competent in the debriefing process. So again, when we are doing virtual screen-based simulation, we want to make sure that our debriefers have training and practice, and that they are competent and able to facilitate a good, robust, engaging conversation. And we also want to make sure that we're using a debriefing method that is both theoretically derived and evidence-based. So we want to make sure that we have the elements of theory in that debriefing so that we have a good learning experience and get those learning outcomes that we're looking for. We want to make sure that debriefing supports confidentiality and trust. So with screen-based virtual simulation, we still set the safe container, just like we do in all the other kinds of simulation we do. We start by establishing an environment of trust and an environment where we can have a robust, confidential conversation where everyone who's participating can share truly what they experienced without judgment or concern that by revealing the thinking behind the actions, somehow there's going to be retribution. So again, we support this debriefing is supported by this safe container.
Excellent.
Criteria.
Oh, I'm sorry.
Go.
Please
No,
continue.
there's a
No, I
couple
was
more
going to say,
criterion. Yep.
and debriefing is really where many argue that's where the learning occurs, right?
It does. And so in order for that to happen, Criterion 3 is that debriefing has to be facilitated by a person who has devoted enough time to effectively debrief. So there's kind of a couple things in there. You need to make sure that you have allowed sufficient time for debriefing. And many times debriefing is significantly longer than the actual simulation scenario itself, so that you can dig deep into, again, the thinking and the actions and get a good understanding about what the participants were processing as they were caring for the simulated patient. And then you also need to make sure that your debriefing is congruent with the simulation objectives and outcomes. Now, people get confused about that one all the time, because it doesn't mean that you just debrief to what you wanted to happen. You actually have to debrief to what actually happened. So the objective might be that the participant does one thing, but if they never get there, you have to also focus on what happened that they didn't get there. You can't just devote your time to debriefing on what was intended to occur. So we keep the objectives forefront, but we also make sure that every debriefing is individualized to the experience that this particular group of learners actually had.
Wow, thank you. That's a great tee up to the scenario that we're about to watch. We'll see that in just a few moments. And then after that scenario, we'll come back and we'll hear a few more comments from you, Doctor. Thank you.
Okay. Good morning. Thanks, Alicia and Alyssa, for joining us for today's telesimulation as part of our MedSurg simulation course. You can see on your screen, we've also got Bruce joining us today. He's playing the role of your patient, Kenneth Bronson, today. Last week, we spent a bit of time getting comfortable in this online environment, but we didn't actually run a simulation, which we'll do today. And I wanted just to go back and remind you of some of the key points of how we can best interact in this virtual environment. Since we're in a small group, I think we can all keep our microphones unmuted. That way it'll be easier to have conversations. Unless you've got some background noise going on at home, then you can turn that off. For the purpose of the simulation, your video camera will indicate if you're in the room or not. So when we're ready to get started, I'll turn my camera off, as well as anyone else who is outside the room. And then as cameras pop back on, you'll know that those people are in that patient environment. If I turn my camera on during the simulation, it will probably be to clarify some piece of information or make an adjustment, just like I might pop back into our physical simulation lab on campus. What will be really useful is if you can verbalize as many of your thoughts as possible. This really helps your instructors give you better feedback, give you credit for the critical thinking that's going on in your head, which sometimes isn't as easy to see in the virtual environment. So if you can speak anything that comes to mind out loud, that will be really helpful. After the simulation session virtually, we'll take a few minutes and then we'll regroup and do a debriefing, just as we would in our physical lab. Do you have any questions for me before we get started?
No.
At this point, Alyssa, I'll ask you to turn your camera off to indicate that you're out of the room. And Alicia, you'll be our first student nurse responding to this patient. And we'll have a brief look at what we know about Kenneth Bronson. Kenneth Bronson is a 27-year-old male that was just admitted to the medical ward from the emergency department. He presented to the emergency department with a cough, chest pain, and fever 2 hours ago. A chest x-ray revealed left lower lobe pneumonia. An IV of normal saline has been started at 75 milliliters per hour. He is receiving oxygen at 2 liters per minute by nasal cannula. His saturation on room air was 90%, and that has increased to 93% with the supplemental oxygen. He had a temperature of 39.2 degrees Celsius, or 102.5 Fahrenheit, and was given 1 gram of paracetamol in the emergency department. Pharmacy has just delivered the ceftriaxone IV, which is due to be given. It's 11 o'clock, you're in the medical board. In terms of Mr. Bronson's past medical history, he's generally healthy. He was seen by a general practitioner 6 months ago with strep throat, and he received penicillin and had an allergic reaction, which he described as a generalized itching. He smokes 2 packs a day of cigarettes and has been doing so for the last 10 years. In his recent medical history, he's had general fatigue, fever, and a productive cough for about a week. He started to have chest tightness and difficulty breathing, which brought him to the emergency department. And he's now on the medical ward where you're with him.
Okay. Good morning, Kenneth. My name is Alicia. I'm going to be the registered nurse here with you today. How are you doing?
Hi, Alicia. I'm okay. How are you?
I'm doing well, thanks.
Okay.
I'm just going to grab a set of vital signs on you at this time. At this time, I would also like to do a focused respiratory assessment and auscultate your lungs.
Okay.
Okay, so I did hear some crackles in his lungs and decreased lung sounds in the lower left lobe. Your oxygen saturation looks good. I'm going to check that your IV site is okay. You're currently running normal saline at 75 cc's an hour as per the doctor's orders. So Kenneth, I'm going to leave you here with your call bell now, and I'm going to go check what Dr. Yon has ordered for you. And if you need anything in the meantime, you give me a call.
Okay.
So I can see here the orders. So the doctor's ordered oxygen to keep sats greater than 92%, normal saline, 75 mils an hour, vital signs Q4, and he's ordered ceftriaxone 1 gram every 12 hours. And Tylenol was just given in Emerge. Okay. So at this time, I would go and do a further patient assessment on his recent penicillin reaction. So Kenneth, I saw in your report that you were recently prescribed an antibiotic called penicillin by your general practitioner or your family doctor. And it said that you had a reaction. So I was just wondering if you could give me some more information on that reaction and what that was like for you.
That was about 6 months ago. Okay. And I took it, and Alicia, I felt kind of just itchy all over.
Okay. Did you have any shortness of breath? Were there any hives in and around your mouth? Did your tongue swell? Any symptoms like that?
No, I don't remember anything like that. I would have remembered that.
Okay, and were you able to finish the dose of the antibiotic, or was it stopped early?
No, I think you're supposed to finish it, aren't you?
Okay, yes. I just wanted to check and see what the doctor did for you in that situation. So the doctor's ordered this antibiotic called ceftriaxone, and this antibiotic, if you've had a reaction to penicillin before, can increase your chance of reacting to this new antibiotic ceftriaxone. Okay. So I'm going to go verify with the doctor that he'd like to proceed with this order, and then if we're good to go, I'll be back in with your antibiotic in a few moments, okay?
Okay.
Okay.
Emerge.
Oh, hi, Dr. Yon. It's Alicia calling from Med 6. I just want to recheck an order with you regarding Kenneth Bronson, the new admit with pneumonia.
Right.
You had ordered him to start ceftriaxone 1 gram IV piggyback Q12. He recently had a reaction to penicillin with his family physician. He had itchiness all over, no respiratory symptoms. Am I okay to proceed?
Yeah, thanks for calling. Good. Yeah, I saw that in his history. he only had the symptoms once the first time he took it. He didn't report it to anyone, and he finished the whole course and didn't have any other incidents. So that's why I thought we'd be okay with the cephalosporin. So yeah, so let's go ahead. Thanks for checking, and let me know if you need anything else.
Okay, sounds good. Thanks, Dr. Young. Okay, so now that I've received the okay from the physician and I've clarified the order, at this time I would bring in the ceftriaxone and start running it via IV piggyback for my patient. And I would educate him that this is an antibiotic that the doctor has ordered. So Kenneth, I'm just going to be starting this IV antibiotic for you. It's called ceftriaxone. It's just going to run here. It'll run for about 30 minutes. We'll run it over. And if you have any symptoms, shortness of breath, difficulty with breathing, if you notice any rashes or irritation on your skin, general itchiness, anything like that, you're going to let me know, okay?
I'll let you know.
Okay.
Alicia?
Yeah.
I'm starting to feel scratchiness in my throat a little bit.
Okay. So at this time, I would stop the antibiotic infusion. So Kenneth, are you having difficulty with breathing? Okay. I can see that he has labored breathing. And at this time, I'm going to call for help from one of my fellow nurses.
Hi, Alicia. What's going on?
Hi, Alyssa. This is the new admit, Kenneth Bronson. He seems to be having a reaction to the ceftriaxone antibiotic that I just started. I'm going to go contact the doctor. At this time, could you get a set of vitals for me and
Yes.
stay with the patient?
Definitely.
Okay.
Thank you.
Thank you.
Hi, Verge, Dr. Young.
Hi, Dr. Yon. It's Alicia calling back from Med 6 regarding Kenneth Bronson.
Right.
I just started his IV piggyback ceftriaxone dose, and he's experiencing worsening shortness of breath and some throat itchiness.
Oh boy, I think your instincts were right when you just called me, weren't they? Okay, so have you shut the infusion off?
The infusion's been stopped.
Okay, excellent. So let's assume we're having an anaphylactic reaction here, Alicia. I'm going to send these orders through to your screening, but why don't we give him...
Sounds great. Thanks, Dr. Young. Okay, so now that I've received my orders on here, I can see that I need to get the patient on a cardiac monitor. So at this time, I'm going to ask Alyssa to put the patient on a cardiac monitor and get an ECG going for me. And I can see the new med orders that have come through, and I know that the epinephrine is our priority drug at this time. So I'm going to administer that IM.
Perfect. So let's put him on the cardiac monitor and cycle the BP. Also, Mr. Bronson, I'll help you sit up a little bit just to get you more comfortable here. Are we still feeling as bad as before? Okay. So Nurse Alicia is working on something for you right now. And the cardiac monitor is set up for you, Alicia.
Thank you.
Alicia, I see you're just about to use your skills trainer. Could you please adjust the camera a little bit so we can see better?
Yep, for sure.
And then you can continue the simulation. Thank you, that's perfect.
Okay, so I'm going to clean my injection site. I know that epinephrine is given via IM injections. I'm going to pull back the skin. Kenneth, you're going to feel a little poke here, okay?
Okay.
Okay. Okay, so I've given the IM epinephrine. At this time, Alyssa, if you could grab the gravel and give it IV push 50 milligrams and let me know when you've got that.
Yeah.
I'm going to reassess our patient. So I'd like to get a full set of vital signs, and I'd also like to auscultate his lungs.
Okay, so I've done the push, Alicia.
Okay, Kenneth, how are you feeling?
Better now. What was that you gave me?
Okay, so I just gave you an injection. We call it epinephrine. If you've ever heard of an EpiPen, it's the same drug. We just don't have that form in our hospital. The physician and I believe that you had an anaphylactic reaction to the antibiotic that we gave you.
Thanks so much, everyone. Let's take a 5-minute break. If you need to rearrange your desk, grab a cup of tea, grab a comfy chair, and we'll come back and do a virtual debriefing.
Sounds good.
Okay, thank you.
Thank you.
Thanks for coming back, everyone. I hope you had a little bit of a break, had a chance to sit back from the scenario. What we'll do now, we'll go into a debriefing. This could take 2 or 3 times as long as the actual scenario, so we're in no rush here. I want this to be a space where we can really give each other honest and constructive feedback. And our main goal here is not to evaluate or anything in this scenario. This is really to learn from the situation and bring that forward into our clinical practice. So I'll start off with Alicia as our primary nurse responding to this scenario. How did the overall situation with the patient make you feel?
Overall, it made me realize how quickly a reaction could happen in the real clinical setting. It's not something I've ever experienced in clinical, and it's not something that I would feel overly comfortable experiencing in a real clinical situation. So I could see how quickly you could feel anxious in that situation and how quickly things changed.
What is it about that speed that makes us feel anxious?
I think it's about the fact that you have someone's well-being. They're looking at you, needing things, and you're the person that can get it for them. You're the only person.
You remind us what you observed and what led you down your diagnosis of an anaphylactic reaction.
Well, it was really just the sudden onset. I had only just started the antibiotic, and it was already in the back of my mind that he had had a previous reaction. And knowing that cephalosporin and penicillin have a connectedness in terms of the reactions, in the back of my mind, I was already kind of anticipating it in a way. But really just noticing as soon as he complained about the throat tightness, that's always to me a red flag that someone has something more going on when their symptoms have changed, and he wasn't experiencing that before. So that was the big red flag for me.
Alyssa, when you came into the room, Alicia had identified that an anaphylactic reaction was ongoing. From her report, from her tone, did you get a sense of if that was a mild or moderate or severe reaction?
From her tone, she was pretty calm and really confident in what she was assigning to me. I think just by looking at Bruce, I knew it was probably getting, had we not stopped the medication infusion, then it definitely would have got worse. But I think when I walked in, it was you could tell things were under control, and she just needed an extra hand. So that's how I felt about it.
Yeah, I thought that was really nicely done, that through Bruce's body language, we could see that this was a severe situation.
Mm-hmm.
But Alicia's communication made the environment quite moderate and manageable in a good
way.
And then, so Alicia, you had identified this severe anaphylactic reaction. You had communicated with your team. What would you say, what was the key intervention that turned around this patient's course?
I would give credit to 2 of them. So definitely stopping the IV infusion, because we saw how quickly the patient situation escalated, even just with the few moments of the medication administration. And so stopping the medication definitely made a huge difference in the patient outcome. And then definitely the epinephrine was the priority drug that when I got the orders, I knew, okay, I'm going to give Epi first.
For the epinephrine, you were using a modular skills trainer. How did you find that transition from the virtual to the physical? I know I interrupted you to adjust the camera.
Yeah, I felt like it was smooth. Yeah, I just obviously forgot to adjust the camera so you could actually see the scale. Definitely, I caught myself at the end. You know, I did remember to actually tell the patient, okay, you're going to feel a little poke here. Obviously, before giving meds, I like to check, you know, patient name, date of birth, and make sure that I have the right patient. In this situation, given that it was an emergency, I'm going to give myself a little bit of slack for that. But normally, it would be a different situation when you actually have the patient right here. But in terms of actually performing the skill, I felt like it was good. I had all my supplies here that the school had provided, and so it was cool to actually draw up the injection. And while I wasn't in a panic mode in terms of I didn't actually have a crashing patient in front of me, I was on camera in front of you guys, so I did kind of feel almost like a simulated version of that intensity and the anxiety of like drawing up this important med and making sure that I did it in a timely manner while also being safe and making sure everything was done. So
and I'll open it up. Bruce, Alyssa, anything else you want to add to some takeaways from this scenario, things that you can bring forward to the clinical world?
I think to add to that as well, in the clinical situation, if this was a real scenario and I was a nursing student who started this antibiotic administration, the first person I would have called wouldn't have been a colleague. It would have been the primary nurse and my preceptor, which I think obviously then my role in this would have been entirely different. I don't think I would have been the one doing all of the assessments. I don't think I would have been the one to call the doctor. So this actually gave me, I think, more opportunities in this specific scenario than I would have had if this happened in the clinical situation, because you know you're not going to throw all the responsibility on the student when you have a patient that's entering into anaphylactic shock. So I think this actually gave me a unique role versus what I maybe could have been provided in a real clinical situation.
Well, thanks so much all for joining this virtual simulation. I really appreciate your time and your participation in this debriefing.
Thank you so much.
Thanks, Helen. Bye, everybody.
Have a good afternoon.
Bye.
Bye.
Okay, so we've just seen the scenario, and we're hearing commentary from some of the other panelists. For you, Doctor, after reviewing the scenarios, what went well when considering the debriefing?
I thought that the debriefer did a great job of setting the safe container. It was very direct and inviting, and it really set the stage for a great conversation. I also thought there was good interaction between the participants and the debriefer, and that everyone had an opportunity to talk about what went on and how they approached each aspect of the situation with this particular patient. I did think that there was a good conversation about feelings and about how the participants were feeling after the scenario ended. And I did think that it was great that there was a conversation about what was the key intervention and the key issue. So that was really obvious for everyone as they left the experience. It was forefront in everyone's mind, what had occurred and how it had unfolded, and all of the possibilities had been discussed.
I think they did very well. It was great to provide thorough orientation through the briefing in this telesimulation situation, because in the situations, it helps nursing students understand the situation they meet, so how the process goes and their roles. So they could be prepared very well to play their roles and part, and the instructor was able to assess whether they met the running outcomes or not.
Overall, I think they did a pretty good job, so that was really nice to see. So for example, going back to the standards, it's very important to have that orientation, and it was great to see a thorough orientation in this telesim, because what they were able to do is provide an example of what to expect in the simulation, what everybody's roles were, a little bit of preparation with use of video cameras, who's going to be on and off, and what that means. And so those are all really important to be able to sort of again lay that foundation for the simulation. And once again, I cannot overemphasize, how preparation, how important that is in order to facilitate the simulation. And so just talking about facilitation, so you can tell that the facilitator wasn't actually in the simulation. He was turned off. He obviously was in the background. But so I would gather that for the prompts and the cues, that there was obviously some kind of communication between the facilitator and the confederate or the patient, because that was sort of the way to embed those prompts and cues in the simulation. And you could see those throughout the whole activity, which was really, really good. I think there was also a really good transition at the end of the simulation for when you have your active simulation and when it's over, and that very strong verbal cue of saying, okay, now we're transitioning to the next phase or to the debriefing phase, because it's very important for participants to sort of mentally disengage from the active sim and then get ready for the debriefing phase, because it does require a different sort of reflective brain in that case. So it was good to see that sort of transition. So like I said, overall, I think that they did a pretty good job.
Thanks, James. And the people who have run the telesim really have done an incredible job in bringing that to life on a virtual or a distance platform, because the simulations that we have traditionally used, as was the simulation that had been used in that scenario, has been designed for face-to-face simulation. But it does really highlight the value of running a simulation or using the standards of best practice simulation design when thinking about how to shift a scenario that has been designed for face-to-face simulation to what they've called a telehealth or tele simulation approach. And so some of the things that went really well were around the effectiveness of the brief. So the pre-simulation brief was something that was incredibly thorough. Not all of the information, you don't have the background to what was designed in terms of the pre-simulation brief, but it was pretty clear that a lot of thinking and a lot of planning had gone through or had been undertaken in helping not just the participants, but the simulated patient or the actor and everyone thinking about what's going to be required to shift this from a face-to-face delivery to a virtual one or an online one. So the scenario really had very good briefing, not only in terms of the scenario itself, your traditional briefing, but really making sure that people were comfortable and knew what to expect in terms of running the scenario. Now, the other parts I want to comment on around the pre-simulation brief, I guess, but also one of the standards of simulation design is that around using the various types of fidelity. And this was something that there were some fantastic elements put into the design here. The first was simulating the presence of people in a room. So the rules, one of the first things I noticed was the rules around turning your camera on, turning your camera off to signify whether you're in or out of the space. And that was quite good to see, quite enjoyable to watch. Some other areas of where fidelity was considered in a really meaningful way, so to look at the ways that the situation could be replicated in an authentic way, were the ways that they used the patient monitor. The choice of using a simulated patient rather than a mannequin, and the cues and the prompts that were built in to that particular use of the simulated patient, the use of the telephone recording that came across, and even just the roles of the facilitator in the role of the doctor. Were all really nice ways of doing it. But I particularly liked in this scenario the use of the patient monitor. I thought that was really clever. And as well as the visual cues that you got from a simulated patient, and really effective use of simulated patients as well. There was also clear consideration around what artifacts, what elements of practice were really important. So the medications, the syringe, the vials, those sorts of things that were authentic artifacts of practice and what needed to be in that situation for a realistic experience. So they were all quite nice elements to think of fidelity in all its different components. The other part that I think was done really, really well was I think the whole package came together really nicely in providing a nice experience of a rehearsal. And so simulation in itself, there's a number of different definitions of simulation, but one of those is as a rehearsal. And there is no doubt that the situation that was replicated, even though it was kind of like the reading of a play or something in it, or a movie in its very early stages of rehearsal. Everyone sits in a circle and they read off the script and they're talking through the action or the scene or whatever as a rehearsal for a play. I saw this as something very similar, but the emotion that was generated was quite real. So if we're watching Alicia during as the patient's condition was deteriorating, we started to see that the person was having visual signs of respiratory distress. They were unable to speak in full sentences. The monitor was alarming, and Alicia's tone of voice elevated. Her tone of voice, her volume escalated as well. So she was clearly showing some signs, even in a little way, of emotional engagement with the situation, which is always something beautiful to see with simulation in one of the situations or the elements that you want to reconstruct or to generate. So that was great.
Thank you. Now, there's always room for continuous improvement, though, right? So what alterations, what changes could have been made to better align with the standards of best practice in debriefing?
Sure. I think there's probably two things that I would have liked to have seen a little bit more of. When the debriefing began, it began with a discussion about feelings, and then it went into kind of the recollection phase, the recalling what happened. But we skipped over the who is this patient piece. And that's easy to do when we do screen-based virtual simulation. We forget that in order for us to embed this experience into our learners' brains around patient care, we have to attach it to the human characteristics of a patient. And how we do that, how we convert the avatar, or how we convert the human, or how we convert the mannequin into this patient in our brains, is really through those human characteristics, their story. And so a good simulation has a good story, but also we point out the story in debriefing. We talk about what we know about the person. And I'm not just talking about the medical diagnosis, I'm talking about the human piece, because that's how we remember people. That's how we remember situations that we take into practice later.
And stories stick, don't they?
They sure do.
Yeah, they stick, and they allow us to process and remember. So thank you very much, Doctor. Sorry, I didn't mean to interrupt. But thank you very much. Any final comments on the scenario before we close?
The only other thing I would add is that we have to remember that when we recall or we go through what happened, we also have to do that reflection piece. Reflection is really, really the key to good debriefing. And so as you're thinking about each thing that occurred, you really want the debriefer to probe in. And what were you thinking? And what did that mean? And how did you then come to the next decision, so that you, the debriefer, really get inside the head of the learners and really make sure that what you think you saw them do and you think made sense actually made sense as they were thinking about it also.
It's about intent, right? It's rooting
It
out what
is.
their intent is. Sure.
It is.
Sure.
And it's about matching knowledge and knowledge and intent. It's about matching decision making and actions and making sure that everything is in alignment.
Good critical thinking.
Absolutely.
In telesimulation situation, when we try to align more closely to the standard of best practice outcomes and objectives, I think it is very important to think about how much activities that can be performed directly, so which can be assessed or evaluated with SMART SMART criteria to meet the objectives. Even in these situations, nursing students assess the patients only by asking the questions and EKG monitoring. There was a limitation that they couldn't actually see the patient visually. So if possible, in a given telesimulation situations, we can use standardized patients, which can increase the real situation, and in which nursing student can assess the patients and visually and more directly. Also, it is very important to establish outcomes that can be assessed through the direct performance. That's all. Thank you very much.
Right. Well, like everything we do, you can always improve on things, right? So that, of course, is always the case. So in this kind of experience, realism can be challenging just because of the kind of environment. So again, with the prompts and the cues, using your confederate or your patient in this environment, one of the ways to do that is to use them to provide those prompts and cues. So early on, when he was discussing his allergy history, he wasn't really short of breath. His SATs were 94, so I probably would have expected something like that. More just because you want to give the student not a sense of urgency, but to say, you know, not everything is all okay here. So I don't know what kind of communication was what happened between the two, but it definitely would be helpful to see that, because the facilitator really is using that person as their proxy or their voice to speak in that simulation. Having said that, they did this really well when the patient went into anaphylaxis. So I would have just liked to see that a little bit more throughout the whole simulation. Now with the simulation itself, we're just seeing one part, just the actual live simulation. So it would have been nice to see what other kinds of materials or preparatory materials were provided to the participants prior to the simulation, because again, that sort of sets the stage for the simulation. So they are small, but they do add up, and they can affect how the facilitation unfolds, which ultimately can also affect how the debriefing unfolds in that simulation. And just while we're talking on this topic, one thing that I just sort of wanted to add that I've been noticing in the past little while is we're all seeing this real surge in virtual simulation use, which is great. I understand it's out of necessity, and a lot of people are jumping into the deep end of this simulation, this virtual simulation world, without not necessarily having that background in simulation pedagogy. So what I'm seeing and hearing in different kinds of areas are that people have the same kinds of concerns or same kinds of struggles that we had maybe 5 or 7 years ago with in-person simulation. And we're now just seeing that coming out in the virtual simulation. We're trying new things, seeing how this works, seeing how this doesn't work. So we are a little bit behind in terms of the pedagogy of virtual simulation compared to where we are with in-person simulation. Having said that, I think that we will catch up really quickly just because we do have some background and great groundwork in our understanding of the pedagogy of teaching with simulation. And I think we're starting to see, like we're doing here, applying these concepts in a slightly different kind of simulation experience. So like I said, I think we'll catch up really quickly, but we are a little bit behind. So just, be kind with yourself, know that you're just learning, and but just always go back to the basics and apply them to your new environment, and you'll find that you'll be a lot more comfortable doing something more like that.
Yeah, so one of the big things that was a standout for me was really the purpose of the simulation scenario itself. And I don't mean that in a way of what was the point of it, because clearly understanding anaphylaxis or providing students with a situation of or an experience of a deteriorating patient is clearly there is a purpose to that. But for this particular scenario, particularly if we apply the INACSL standard of best practice for simulation design to thinking about running scenarios via virtually or via a virtual platform or by a distance platform where we would otherwise do it face-to-face, is why is this situation important and why are we running this particular scenario for this cohort of students? And the INACSL standards of best practice for simulation design focus very clearly on that. And in the first criteria for that standard is to run a needs assessment. So it might be implied or it might be conducted, but we just didn't see it because we weren't privy to that design element or that time from what we saw in the scenario. But I'm thinking that the comment I've made really does then stem to the next criteria for the INACSL standards of best practice simulation design, and that's around the reason for constructing measurable objectives. So whilst the scenario was run and there was a good clear briefing, pre-simulation brief, and the scenario ran well and there was a nice debrief at the end, the scenario itself, the students were never really provided with an understanding as to why this particular scenario is important to them. Why is it important to nursing practice? And there was an absence of learning outcomes or learning objectives stated either in the pre-simulation brief and also at the end in the debrief to provide a context for that learning. And so there was undoubtedly learning had occurred. We heard the conversation in the debrief, but how it actually related to this particular scenario and why that was important for these students, it wasn't clear. And that was probably the biggest element, I think, that could be an area for improvement. The other part that would be really, really important, and again, it might be something that we just didn't see in that particular scenario because it's more to do with the facilitators and the designers of the simulation or the people who run the simulation. And that comes round to pilot testing, and it also comes to evaluation. So pilot testing in this scenario or in this situation would be incredibly important to see how well it's going to work and what might work and what might not work. Now, my hunch is that they did do some pilot testing because there's no way, my gut feeling is that there's no way that you'd run that scenario for the first time and get a successful outcome like they did. Yep. The other part, there were just too many moving parts. But one of the things that would be incredibly important for this is to make sure that there is an opportunity to evaluate. So from a student perspective, or a learner perspective, and from a facilitator perspective, and indeed from possibly a simulated patient perspective as well. Because if we are shifting simulation that have otherwise been run face-to-face, if we have a culture of face-to-face simulation and all of a sudden we're swapping that or we're moving to more of an online or a distance delivery, we want to understand what it is that we're doing and how effectively are we doing it and what are the pros and what are the cons, so we do get a better understanding of what it is that we're doing.
Welcome back, everybody, and a big thank you to our 4 international key thought leaders and to our team in Canada for helping put on that virtual simulation. It was inspiring, creative, and a wonderful example of how to demonstrate the best practices from the INACSL standards of best practice. So joining us now, we have 3 of our international key thought leaders. First, I'd like to welcome back Associate Professor Stephen Guiney, the Associate Dean, Learning, Teaching and Professional Experience at Australian Catholic University. Yun Kang. Dr. Kang is the Director of Global Nurse Education Centre at the Nursing College Daegu Science University in Korea. And Dr. Christina Dreyfus, Associate Professor and Director PhD Program, Marquette University College of Nursing, Milwaukee, Wisconsin. Hi, welcome back, everybody. So firstly, can I say a really big round of applause and thank you for our 4 international panelists for the wonderful presentations they've all given us. Everybody, a round of applause, thank you. And to our team, and particularly our amazing undergraduate nursing students who were exemplary students. We've got a number of questions, and I'll pose these in order. So the first question is for Steve Guiney from, are there any templates available that can be used when designing and evaluating scenarios, either face-to-face or remotely? Steve.
Yeah, that's a really good question. There is actually a whole range.
Muted, Steve.
Am I? Okay, can you hear me? Yeah, got me now? Lovely. Thank you, Yun. Look, there are a number of templates, quite a lot of templates about actually. If you do an internet search, you can come across a whole wealth of templates to help design simulation scenarios. There are simulation templates from the National League for Nursing in the United States, different simulation bodies and communities internationally would be able to put you in contact with people who can either themselves or can provide a range of templates. And so it really is a matter of having a look to see what is around at a starting point. And it can be a little bit difficult to know what sort of template is going to meet your needs in the design of a simulation scenario. And it's good to have a play around with a range of different templates to see which ones work for you, because each simulation program and each facility is likely to have a particular flavor. You might have a particular skill set in your simulation team. Even if it's one person, then your simulation team is one person. You're going to need to have particular criteria in there. So it is good to shop around and either use templates such as the Laerdal templates as well that you will see from the simulations that come from Laerdal, but to see what's going to work for you. Be very cautious though when you're starting off with templates that you get stuck with a template and following it to the letter and then finding out that you actually miss important characteristics or important content that may not be included. So I guess it's hard to know what you're looking for and how to be cautious when you're not really sure what it is that you're looking at, but that will come with experience. In terms of evaluation, that's a really interesting question about templates for evaluating simulations. There are certainly programs around that help you evaluate the quality of simulations, either as programs, either simulation activities, or indeed the quality of, or the experience or standard of the person or your faculty who are delivering the simulation. That's a really complicated answer, but to say that ultimately, if you're looking at in a really simple way, if you're wanting to know how to evaluate your simulation, I think when you're planning it, when you're planning your simulation scenario, have a think about what are the quality outcomes. What is it that you ultimately want to achieve right at the start? And then just pop down a couple of questions to ask yourself when you've run the simulation, questions that will help you answer whether you've achieved those particular measures or not. And I think that's probably one of the easiest ways for you to determine whether you're running a quality simulation or not and to evaluate it.
Fantastic. Thanks, Steve. Before the next question, it's possible to get a copy of the recording. And I can say comfortably to everybody who's online and everybody who's registered, we'll be sending out in a couple of days a copy of the recording for people to be able to review or share with colleagues. Next question is to Christina. I'm inexperienced in debriefing. Are there any tips or suggestions that you could suggest to build my confidence in debriefing for a novice debriefer?
Absolutely. I think that the first tip I would give you is to remember that your job as a debriefer is to ask questions. You're not there to lecture. You're not there to provide answers. You're there to give prompts that will help you to be the guide by the side. So remember your Socratic questions, and when you feel yourself jumping in with the answer, stop, wait, and let the learners jump in. And sometimes it takes a moment for them to process what you're asking. So again, be comfortable with silence. And if the silence gets too uncomfortable, then talk about, okay, so if we don't know this, where do we look? Where do we find the answer? Rather than, again, giving them the answer. Your job is not to do that. Your job is to generate the discussion. And be kind to yourself. Debriefing is something that takes some time and some skill. And so if it's something that you develop over time, and so you may feel like, oh, it was awful the first time. That's okay. Do it again and again and again, and you will get better at it. I promise you.
Great advice. Thank you. Thank you very much. A third question here for you. I'm looking to run a remote learning session shortly, but can't seem to clearly define expected outcomes for a scenario. Are there any elements I should be addressing to make the objectives clearer?
Thank you very much for your questions. We have had the same concerns here. So to have achievable outcomes, it is necessary to construct measurable objectives. So you can use INACSL standard outcomes and objective criteria. Especially, we make sure SMART objectives based on expected outcomes. To make objectives clearer, I think we need to consider two main things. The first thing is how much we can provide